pleasure to welcome Professor Adrian Bloor to talk with us today and to answer some, if not all, of your questions. And I can see that we've got a good number in already, Adrian, 40 odd, plus the ones we'd had pre the meeting. Over to you for a moment.
And thank you everybody for attending and for the invitation to speak. Apologies, but as you've heard, I was asked to step in. Ben's unfortunately not well, and due to clinics and other things that got in the way, I wasn't able to put together a presentation. I'm a haematologist. I work at the Christie Hospital in Manchester. I've been working here for 15 years, and my practice has been in CLL and also trials and transplantation and cellular therapy. So I have a sort of fairly wide-ranging practice, two parts to what I do. And I think that in terms of coming back to the subject, where do we go now? What does life look beyond COVID? What does CLL look like in the future? May not be a big surprise. This is something that I get asked by every patient I see in every clinic that I do. I hope I have some level of insight into this in terms of being relatively close to it, but I'm not a spokesman for the government. I can't speak for government policy, and as you'll be aware, much of what happens is politically motivated rather than scientifically motivated, and so some of the things that come out, it's difficult to know what the evidence is and how it applies to us trying to either look after patients living with it, or more broadly looking at healthcare. I thought the most useful thing that we could do, and we discussed it with Lewis, is that COVID's the big ticket item here. Where do we go beyond it? And in order to make this relevant, rather than me talking at you, I'd like to try and focus things on the questions that you have, and see if we can address them, and whether that can be helpful in terms of where we go beyond this. I think if I was going to say, what do I see the future holds? If you'd asked me a year ago, like many other people, I would have said that during 2021, I thought we would be seeing COVID coming under control, and boy, wasn't that wrong. And here we are in 2022, and still with a huge uncertainty about what the future holds. I think on a positive note, there is now genuinely some room for optimism in general, and hopefully that will extend to people living with other medical conditions, vulnerable adults, and as to how we can come out of this. There's a number of things that come with that. The onset of Omicron at some level may be beneficial. I saw a statistic recently that a third of the infections in the UK have happened in the last 8 weeks, and that huge explosion in the number of cases and the prevalence that we've seen will lead to more people developing resistance to it. And the other question is about the severity of infections. I don't know formally what the severity of COVID is, Omicron versus Delta in immunocompromised individuals, but where I sit at the Christie, a year ago, we were immunized. We were trying to immunize from infection. We were trying to treat our patients and not treat COVID. And the world was a horrible place, certainly if you were in hospitals. What we've seen with Omicron is that we've got a lot of COVID at the Christie, as many people have, but we're not seeing severe infections. And that includes our cancer patients. I can't speak specifically for the CLL population here, but all of our patients in a cancer centre, they are all vulnerable, and we're not seeing that our intensive care is full. And so it may be that as we're seeing, if COVID does what other infections do, they tend to become more transmissible but less infectious. And so we may just be seeing that this is the beginning of something at the end, whereby the acute healthcare consequences in vulnerable people may not be as significant as they were previously, although this is very much a watch this space, and we don't know what's around the corner, what's going to be the next variant of COVID that's going to come through, because we certainly haven't seen the end of it. The other things in terms of optimism, and maybe we'll have some questions about this, vaccination has been successful. It's challenging in CLL patients, clearly because of the relative lack of efficacy in vaccines compared to the general population. But as the population at large becomes vaccinated or immune, that does have a benefit in terms of the fact that the transmissibility of the infection to vulnerable people becomes somewhat less. And the newer antiviral drugs that are coming through have shown some promise. So when combined with vaccination, newer drugs and a potentially less severe infection, that we may see that the challenge that we face with COVID during 2022 is less. It will certainly be different, but obviously that remains to be seen. I guess the other thing is coming as to where we go going forward, and whether we're going to have any chance to talk about this is in terms of progress in CLL. It's important that we don't lose sight of the fact that progress is still being made. We are still seeing new treatments coming through. There was some interesting data that came out at the American Society of Hematology, the ASH meeting at the end of 2021, really looking at the impact of newer therapeutics, so combination treatments, BTK inhibitors in combination with venetoclax, I think looking very interesting. And we will be seeing the results of the FLAIR trial, which some or many of you may have been part of, coming through over the next year, which I hope will mean that we are going to see further step changes in how we treat CLL. One of the challenges, though, is I think if we are faced with how do we balance in immunity versus CLL efficacy, what is the impact of the treatment on COVID? Should we be looking at long-term treatment? Is time-limited treatment better? What's the impact on vaccination? Some of these things are going to have to be taken into account. I don't have specific answers for that, but I think that COVID is clearly going to be something that we're going to have to take into consideration continuously when thinking about what treatments we have coming forward and how we apply those in the best way. So it's sort of a bit of a preamble, but I think that really focus here is to look at the questions that have been coming through and see if we can shape this in terms of answering some of those. So Lewis, it's going to be a sort of a conversation between the two of us, really, and trying to focus this on the questions that have been submitted, and then we can pick up some of those that I can see are coming through the Q&A.
Yeah, okay, well thanks for that introduction. Just picking up on one thing very quickly, you mentioned the FLAIR trial, and somebody here is asking about static. Do you know when static is? Have you been talking to Peter on this subject?
Yeah, I'm on the trial steering committee for static, and it's a matter of everyone's deep regret that static has not opened more quickly. Imminently, I would say, is where we're at too. So static got held up for a number of things. It had regulatory it had a funding approval 2 years ago, and it has been mired in endless discussions with pharma, essentially, going backwards and forwards. They have now concluded, and static will be opening soon. One of the things that's also being looked at there is whether or not there is any way of access to ongoing treatment for people who aren't in static, who aren't eligible because they've now fallen out of FLAIR and they've finished their treatment. I think we will have more concrete information about that, but in the very near future. But it's something that we know that FLAIR recruited 30 patients a month or something. There will be 30 patients a month who are coming off treatment. Not all of those will have had ibrutinib, clearly, but in whom that it would be desirable, if we could to be able to look at static being an option for them in terms of just being able to address the question of ongoing treatment, but imminently, I would say, but I don't have a confirmed date yet. One of the other things about it is setup. I mean, I think that COVID has imposed huge restrictions on many trusts' R&D departments, and so the ability to be able to set trials up locally, certainly at the Christie, has been significantly impacted because of staff redeployment. So I think I would say that there's likely to be some degree of latency, which will be variable to different centres because of the interval between the trial opening and actually being able to open at sites. So it's a watch this space.
Makes sense. COVID rears its ugly head, of course, everywhere. So let's try and tackle the nub of the questions that are being asked. A lot of them are coming in about access to the fourth vaccine, third and fourth vaccines, interestingly enough. And I know that we've had a number of requests into CLL support, and I have a sort of answer, but I just wondered if you had a view on, if people are having trouble persuading either their GP because the GP doesn't understand about vulnerability of CLL patients, whether you had a view of an approach that they should be taking.
Yeah, much of what I'm going to say is going to be the same, in the sense that the guidance that's come out for how people are vaccinated has been applied largely at the majority of people. So the systems that are set up are for the public at large, rather than with reference to vulnerable adults, vulnerable individuals, or to CLL patients. And that's been difficult because the GPs haven't caught up with it, and there's been some real mixed messaging that's come out in terms of who should be who should be receiving this. My take on things is that, I mean, we know from the data that if you just look at cancer patients or CLL patients overall, there's an increased risk of COVID. Now, of course, this all comes out from Alpha variant or Delta variant is less clear about what the impact is with Omicron, and clearly not all CLL patients are the same. So, if you are in the midst of having treatment, have no response to vaccination, heavily immunosuppressed, recurrent infections, low antibody levels, then that's very different to somebody who's got a lymphocytosis of 5 and absolutely no other symptoms. I think it's fair to say that at any stage, even if you are a 50-year-old, otherwise well person with a lymphocyte count of 6 and nothing else, you are probably slightly more vulnerable than you are as a 50-year-old with other problems with lymphocyte count that's normal, but the magnitude there is not that great. What's been left in terms of vulnerability is it's very much down to secondary care. It was put out to hospitals to say, please identify all your patients who are vulnerable, and tell the GPs and write to them and sort out where they're going to go for their 4th vaccination, which has meant that it's just become hit and miss. My take on things is that nobody is disadvantaged by having a 4th vaccine. More is more. We've seen that antibody response improves with sequential vaccinations, and we know that antibodies do not hang around necessarily for a long period of time, so we're not going to be disadvantaging people, with a few exceptions of people who are allergic, who have terrible reactions, but I mean that's very, very small print. It does depend though on individual patients taking control of their disease sometimes and really pushing it. At the Christie, what we did is we just looked and said, I thought pretty much as a blanket, all blood cancer patients, it would be better to identify them as being vulnerable and say they got the 4th vaccine, because going through, we just don't have the ability to be able to look at all our patients and say, well, this is somebody who's very vulnerable and this is somebody who's less vulnerable, so let's just look at them all. And when asked the question, I just look and say, well, everybody should get it. And it does come down, though, unfortunately, for secondary care, so your hospital being able to tell your GP or vaccine centre that you are vulnerable and that you need to be able to get it done. My experience of using this is that some GPs are really proactive and really good and will go out and make it happen. That's probably the minority. But the other thing is that vaccines are widely available. There's huge stock of them. And if you pitch up to a vaccine centre saying, I'm a vulnerable person, I'm being treated for whatever stage, I've got CLL, I've been told I need it, I've not known anybody that's been turned away. One thing that can help, though, is having a letter just to be able to say that it's been recommended. That can come from the GP, it can come from your consultant, your CNS, wave it in front of them, all happen, and just say, I would just suggest if you've got CLL, get it done, because you're probably going to be better served by having it than not having it.
Well, I completely agree. The issue for some of the people here today is that they are unable to even get that letter.
Yeah.
And that's what CLL support have found, some of the trustees and members, is just taking your vaccine cards, maybe even the card that you get from the hospital about your clinical vulnerability, and taking it into a vaccine walk-in centre and having a chat with the person in charge gets you through the door.
I agree with you. I think very few people get sent away. I mean, if you've got a copy of a letter, even something that comes from your GP or from the hospital that's, that even says, talks about the fact I'm seeing this patient for treatment of a blood cancer. There were supply issues originally with the vaccine. It was quite difficult, but the country is awash with vaccine at the moment, so it's very difficult for someone to say no. You'd have to front.
The other thing that I found was that when I was trying to get my fourth vaccine, when I initially went onto the NHS site and applied, it just looked at me and said, well, you've had 3 vaccines, go
Yeah.
away.
Yeah.
But if you, and what we decided was that if you were trying to apply within 91 days of your 3rd vaccine, that it was going to throw you out because you have to wait 91 days. But after the 91 days, it wasn't a problem. And when I walked into my local vaccination centre with my cards and said, can I have a 4th vaccine, please? The first thing they checked was the date of my last vaccine. And once they'd seen that I was more than 91 days through, then they were happy to have the rest of the conversation about vulnerability.
I agree with
So,
you. There is no, the system itself is not set up in a way that you can identify yourself as being vulnerable and therefore book yourself on that basis.
yeah. So the ideal is get a letter from your hospital or your GP, and you've just got to keep pressing them to come up with that letter to enable you to get the vaccine.
That's the ideal thing, and I'm aware of the fact that some hospitals, some consultants and some teams are more approachable and more responsive than others. I can speak for what happens where I work, but I know it's not the same everywhere. But I think, as you've said, Lewis, if you go along and actually just identify yourself to the centres, then generally speaking, they are receptive to that.
Yeah, which brings us to the follow-on really from that, which is access to the PCR test and the antivirals that you mentioned earlier.
Yeah.
And again, the issue is if I don't have a letter, then how do I get access to those things? And how do I get hold of a PCR test? Any advice there that we can offer?
Okay, so in terms of getting access to a rapid PCR test, I mean, all of this is centrally controlled. This is one of the difficulties, is that GPs and most secondary care centres do not have access to it. So all of the new all of the PCR tests, the rapid PCR tests come out centrally. And all of the new antiviral treatments, so that's sotrovimir, molnupiravir, which are the 2 that are available at the moment, and Paxlovid, which will be coming out in the very near future, are currently only available through COVID medicines delivery units, or CMDUs. So each region will have 1 or more CMDUs. Now that might be in your hospital. If you're a patient at Christie, where I work, the CMDU is at the Manchester Royal Infirmary, which is 3 miles up the road. And for those patients who are under district general hospitals, it's likely that it's going to be the sort of regional centre. There is a hope that that's going to be moved so there's more wider access, but at the moment it's down to drug delivery. It's drug supply issue that's been concentrated on a small number of centres. In order to get the treatment, you need to get a referral into the CMDU. Now, I think I saw some of the questions about who is eligible. On the guidance, which is in NHS England guidance, CLL is one of the conditions that without qualification means that you are considered to be eligible. And it doesn't speak to whether you've had treatment, whether you've got stage A disease or anything else. It's just blood cancers, CLL, not otherwise specified, means that you are eligible. So I think that, and I've not heard anything that would suggest that that's going to change. It may be that other things will change in terms of eligibility, but I don't think there's any move that CLL would be one of those things. The 2 challenges of getting it, one is, can you get the PCR test, the priority PCR? Well, that's difficult because you had to be on a list by the 10th of January, and if you weren't on a list by the 10th of January, then it didn't get sent out to you. The only recourse in terms of the official way to get a rapid test is through 119, because hospitals don't have them, GPs don't have them. You can't get in contact with the CMDU, so the only way is pursuing 119. And whether that works or not, that's a matter. But that's supposed to be the route, in the sense that if you receive one and it breaks or you lose it, then 119 should arrange for you to get another one to be sent out. But as I say, whether that works in practice, I think it's variable. If you don't have a rapid priority test, then you just need to get a test done as quickly as possible, because one of the challenges of getting the new drugs is that you have to be eligible, you've got to be within 5 days of your test. And that's the first barrier, is that once you go beyond those 5 days, then you stop being eligible for the treatment and you won't get it. And so if you do get a test, if you get symptoms, get the test quickly. Now, there was a real issue with getting tested at the beginning of the month or around Christmas time, because the system was overwhelmed. But certainly where I work, that's now become much, much easier in terms of just going through the normal thing. I've got symptoms, you book yourself in, get the test done. If you're in the system and you've had a priority test, my impression is the system works well. That goes in. If it's positive, someone rings you, they make the referral to the CMDU, and it happens from there. So under those circumstances, it works pretty well. If you haven't and you can't get a priority test and you've got COVID tomorrow, get a test done, and then what you then need to do is to get a referral into the CMDU. Now, that can be arranged 3 ways. You can't do it yourself, unfortunately, although all the CMDUs, it's on the CMDU directory. If you look for it, you can Google it and find out where your local one is. But the referral needs to come either from 119, from your GP, or from your hospital. And anybody in the hospital can do. They just need to send the results through. And it's like getting the 4th vaccine. If you're not on the list and you need it, unfortunately, there's no other way of doing it but to pursue it. And maybe you have to pursue it in all of those 3 ways. If you've got a really good GP and they're proactive, I hope they'll help. If you've got a contact with your CNS, they should be able to help. Otherwise, it's hanging on the phone with 119 and saying, I am vulnerable, I'm on the list, I've got a positive test, and you get the referral in. Beyond that, in terms of getting the treatment, the other thing that can be an issue is which treatment you get, because of the 2 drugs, sotrovimab is probably the better drug in terms of efficacy. So both of the drugs, the principal benefit is they stop people getting severe COVID. So they stop you ending up in hospital, stop you needing oxygen, reduce mortality. And they work in people who've got mild infections. Molnupiravir, originally the data suggested it had about a 50% reduction in the rate of severe infections. More recent data suggests that might be 30%, so it's modestly effective. But if you're immunocompromised, it's better than doing nothing. It doesn't appear to have lots of side effects, or appears to be a safe drug, admittedly with short follow-up. Sotrovimab is given intravenously, and one of the issues there is capacity. So you may go all through those hoops. You've got COVID, you've had your test, you've been referred to the CMDU, you've been told actually sotrovimab would be a good treatment, and then nobody's got the capacity to do it because they haven't got any beds or staff to be able to give it to you. And then there is a drug supply issue. It's not entirely straightforward, but if you get into the system, it will happen. Where I think that I hope we'll see things going is with Paxlovid. With the data for Paxlovid, I don't work for Pfizer and don't have a sort of fixed belief here, but it looks better in terms of its efficacy. And that might end up being the drug that more people get, because I think it looks like it's probably going to be more effective than molnupiravir. Now, the issue there that makes it even more complicated, and this is one to watch, is that Paxlovid interacts with loads of other drugs, including venetoclax and ibrutinib and acalabrutinib.
Oh, joy.
So I think there will need to be some backwards and to and fro, and so you need to tell them that you're on treatment. And what will happen is the CMDU will contact your team and say, what's the issue? But I think for awareness, from my perspective, and so we sort of discussed this with colleagues, Paxlovid is a 5-day treatment. There are very, very few indications where somebody with CLL can't stop taking ibrutinib for 5 days. If you need to have an operation, you'd stop it for 2 weeks. You need to talk to your team about it. I'm not going to say because I said so it's the right thing to do, but in general, from my practice, I can think of almost nobody that I would say you can't pause it. And that gets around the issue, because my take on it is that if you've got COVID and you've got CLL and your CLL is pretty well controlled, COVID's the big risk. And therefore, I would much prefer somebody to have the antiviral treatment and pause their ibrutinib than to be told, carry on with your ibrutinib and then have some treatment that's less effective. So that's a watch this space thing. And but I was on a call with NHS England last week about this, and they're sort of rolling it out. So I suspect we will see this coming through in the next, well, I hope in the next 2 or 3 weeks. I don't have a definite date because it's got to go through NHS England machinery, but the principle will be exactly the same. It's going to be, you've got to get into the CMDU, and at the moment, that's the way it will work. It may be that common sense will come over, will work such that these drugs will be available through your centre. Now, I don't think it's going to be available in every hospital, but it may be certainly in the sort of larger teaching hospitals that they will have access to it. So you don't then have to go somewhere that's that's a completely separate centre. The challenge is going to be that 5 days. You've got to get your test quickly, and you've got to get into the system. And I can say nothing more than the fact you just might need to pursue it. If you're not getting any joy, keep going with it, because the clock's ticking. And in terms of getting the tests, the priority tests, if 119 aren't playing ball, then it is just getting a normal test and acting on it as soon as possible. Don't wait for someone to call you expecting that they are going to sort it out. You've got to actually go out there and get and pursue it.
And what about does this apply as well if you're on the infamous watch and wait?
Yeah, it does. Now, I mean, I think that I've been asked a question by some of my patients, sort of said to me, I spoke to someone yesterday, lymphocyte count of 8 or something, completely well, and said, well, I had COVID last year, I was fine, and then said, am I really going to go and do all this if I got COVID again? And I think pragmatically, I said to him, well, the right answer or the correct answer is yes, you're vulnerable, and yes, you should go do that. But actually, for an individual, it might not be the right thing to do. And I guess that's a conversation about risk. And it was one of the questions, how do you risk assess somebody? But I think that, in somebody who is otherwise well, maybe, younger, no other medical problems, no chest disease, no other risk factors. And if you've had COVID before and it hasn't caused any problems, then, arguably you don't need to. But I would say that, in principle, people with CLL should think about it, and it's just it's making that risk assessment. And the ideal thing is it would be a conversation with your CLL doctor, with your CNS about it. But I hope there's some sort of common sense that will be able to come here. Certainly if you're on treatment, then I would definitely say yes. If you've never had treatment, maybe not.
Right, because it tends to be a bit different if you are on watch and wait, active monitoring, then your treatment tends to be with your GP, not
Exactly.
with a consultant, and you won't have a CNS. So the message here is you've got to be persistent. You've got to take this into your own hands and push forward with, the various things that can be done. And the Green Book supports this.
Yeah, I mean, the Green Book is just about vaccines. So the Green Book certainly recommends that's about vaccination. NICE guide, sorry, it's not NICE doesn't decree on these things, but it's sort of NHS Department of Health and Social Care guidance that says this. There are quite clear written guidance about this. The difficulty being is, of course, many GPs aren't very close to it, and they've got all sorts of other things to be dealing with. But it's written down. It's not like it's open to interpretation. And I think that certainly if you get to a vaccine centre, it's very clear who's eligible. I would say that most vaccine centres know about that. If you get to a CMDU, they're doing this all the time, and we're very clear with a list of, and on that is right, you've got CLL, you tick the box, and therefore you're good to go. It's getting into the system that's the challenge.
Right. Okay. Just looking through, so you've answered quite a lot of the questions in your, or some, as we went through. But what do you think is going to be the people who have CLL? What do you think the next year is going to look like? What is let me say, the new normal? So they're advising that we stop wearing that people generally can stop wearing masks. I'm not sure that applies to me with CLL. So what would you be advising your patients at this point?
What I'm advising, I think that, it's something that, and it's a bit like the approach you're taking with Christie, is being very early adopters of being cautious. So, when at the beginning, I think, it's taking a sort of a very cautious approach. So, masks, hand hygiene, distancing, doing things, earlier rather than later was certainly my approach at the beginning of it. And I think that what I would say is that as we come out of COVID, whatever coming out of COVID means, I think for CLL, for CLL patients, it's like it's being a bit behind the curve, I think, because you'll see that every week something's different. The government politically is just enormously keen to have good messages. We're dropping Plan B, don't do everything, go back to work, everything's fine, and because it's a great message. And I think that what I've been saying to my patients is just like, let's sit behind that a little bit. It's not to be totally, not to be totally negative and think that the world is going to be awful for the next months and months and months. But we just need a bit more data. What do the numbers really look like? Is this actually, is this playing out in the way that we hope it would do? And many of the things that can be done, I think, like, wearing a mask does give significant protection against CLL. If you're, as a sort of cultural thing, but I guess we've all got used to wearing masks at the moment. It does protect you. There's no downside to doing it. I mean, they're a bit irritating and, a bit claustrophobia inducing, but generally speaking, it's an easy thing to do. Travel, should you be traveling, everybody on a plane should be tested, but we all know that if you sit on a plane, you have recirculated air, and can we test the people? Can we trust the people that are around us? So I think that, yes, I think that we may see the world opening up a bit, but maybe now is not the time to be thinking I'm going to be going and traveling right at the moment, or this weekend I'm going to go to a football match and stand there with a lot of other people breathing their air. So I think there's a bit about just common sense things, and there is a difference between complete cavalier disregard for any kind of precautions and being sitting in your house and doing nothing all the time and being, it's a fairly miserable existence. I can't speak to it because I haven't done that, but I think the thought of some of people my patients that I speak to who really haven't gone out for 18 months or 2 years or done the thing, that's got to end at some point. And I think that there are things that can be done that are reasonable. In order to catch COVID, you've got to catch it from somebody, and I think there's a balance to be struck here, whereby with some of the sort of just easy, not so onerous restrictions, that you can keep yourself safe, but you can still protect, still get on with some semblance of life. But we just need to see over the next 2 or 3 months what happens with COVID, and I think then things are going to become things will become much clearer. But as I said at the beginning, the hope would be is that 95% of the population has antibodies to COVID now. Omicron is definitely going down. New treatments are there. People are having vaccinations, and for many people, including many people with CLL, things can improve. The other thing is, I think there's a cumulative effect in terms of protection. So there were some studies that have looked at sort of what happens with vaccine responses, for example. And many people will be familiar with the study from Birmingham, because the headline rate of 34% vaccine response with CLL, which is, it's true. And the vaccine response in people who've got CLL is less, but it can improve with time. And it also depends on, if you're on treatment, where you're up to with the treatment. Has it stopped? And therefore, if you keep plugging away at it, there is a possibility that for some people, you will see, well, you don't respond after 1 or 2 doses of vaccine, but with the 3rd or the 4th dose, that you can see that people who hadn't will actually develop responses to the vaccines. And so I think that's another thing, is that, it's not fixed in stone. Where we're at now, or where you're at as an individual right now, is not necessarily where it's going to be in 2 months, 3 months, or the rest of the year. And ultimately, we've got to, COVID's never going away. I see every year my patients, CLL patients, transplant patients, who end up being unwell with viral infections, respiratory syncytial virus, paraflu, flu. Some of them get really sick. Some of my patients die. And, this happens every single year. and we have to be able to get to the point where we can live with it. And actually, many of the things that if we do and we're careful about it, do protect him. It's not a coincidence that there was no flu last year. People were distancing, people were being careful. Now, the population at large isn't going to do that, but there are still things that actually vulnerable people can still do. Wearing a mask, not putting themselves in huge crowds or exposing things that will significantly reduce the risk of getting infections, but without meaning that their life comes to an end, or enjoyable life comes to an end.
Yeah. Interestingly, I was reading somewhere that last year one of the reasons why so many infections were going down was because, particularly for infant school children, they were being made to wash their hands multiple times a day, whereas normally there wouldn't be any of that, and then they were passing those infections on to grandparents and so on. I'm sure grandparents would rather have that problem than not see their grandchildren, but that's a different thing. Switching the topic slightly, we haven't finished with COVID by any means, but switching the topic slightly, there's some questions about understanding of CLL. So how many GP surgeries really understand CLL, and how many GP surgeries are aware of the treatment pathway for immunosuppressed? And we see this from time to time. So it does vary from surgery to surgery. GPs, when you think about, we have, 30,000 CLL patients in the UK overall. About 4,000 are diagnosed every year. Is that a reasonable number? And there are 10,000 GP surgeries. So you're going to see a new CLL patient come in every 2 or 3 years to your GP surgery. So, surgeries aren't particularly familiar. So what would you recommend here? What should people be doing about, and we heard it a bit on the Ibrutinib video as well, where I think it was Kevin was saying his GP didn't really know about Ibrutinib.
Yeah, I think in terms of GPs in general, I can speak, what do you learn at medical school about CLL? Not very much is the answer. Hematology is a bit of a, it's something that there's not a huge amount of it in the medical curriculum. And what I started off in hematology as a house officer, as a means to, because I didn't want to do geriatric medicine, so I did hematology instead because I didn't really know much about it, so it seemed quite interesting. And anyway, I worked with a guy called Robert Marcus in Cambridge who was very inspirational, and that's why I decided to want to do hematology. But at the point where I went into it, which I guess is where GPs are, almost nothing. So its existence, but don't really know a great deal more about the disease. And in terms of therapeutics, I would say almost nothing. GPs will have no knowledge at all about, broadly, maybe about chemotherapy and some of the supportive care, but really nothing about some of the newer treatments. I think that where GPs do really good things, and many GPs are excellent. I certainly don't want to sound like I'm running down GPs. They have an awful lot of stuff that they know about that I know nothing about. So it's they have to have expertise across a wide range of conditions. But I think it's important that people who are diagnosed are able to be educated themselves about the diagnosis. So seeing somebody who knows about CLL to be able to give you the information, to signpost you to be able to where you can get more information, to be able to answer things about what it means, because mindful of the fact that most people with CLL aren't on treatment, and most people diagnosed don't need it at the point of treatment, but knowing about what it involves, what to look out for, where to go, who to call. And I think that it's important that's the interplay between primary and secondary care, so that actually what I try to do is actually sort of, make it clear to a GP, if you're sending someone back and saying, they're being watched and managed with observation, that what to look out for, what it is that we want to be doing, what's important, what's not important, when does a change in the blood count become significant, what symptoms are important and what aren't. And I think that can work extremely productively, but I think as long as the patients are aware and feel they've had the opportunity to ask questions, and that GPs are given a clear steer about what to do and what to look out for, and when to ask for further advice. I think in terms of treatment, it's probably unrealistic to think that GPs are going to know a lot about Ibrutinib or any other treatments, and that's one that that should really be within secondary care. It can be difficult because, I mean, I've had this all the time. People go to see a GP and they mention that they've got CLL on a treatment they've never heard of, and all they get told is, it's like, quick, you must go back to your hospital because I don't know anything about this. But probably with respect to GPs, that's reasonable. But I just think, as I said, it's just making sure that people are given the opportunity to ask questions. And if you feel that you're in the GP surgery and they're not able to ask questions, then just ask. It's not unreasonable to ask for a referral, ask to speak to somebody, and then hopefully you can get the information you need, and then be able to. It's like living with it, but making sure that you know as much as you need to know.
Right. In that respect, I think some of the brochures and things, and particularly the CLL support booklet that we produce, you can either download it or again ask for a printed copy from membership. But that's quite a useful reference guide to take into your GP with you. Some of them object a bit when you sort of sitting there reading the book and saying, well, it says here that, but actually it does help as a discussion point to get a message across if you need to do it. So you might want to consider doing that.
Yeah, I agree. I think it's empowering people to take control over their diagnosis and their illness, and then it's not up to people to be able, hopefully to educate the medical profession, but at least it tells you, the things that the things you need to ask.
Well, exactly, and it also tells the GPs that you're actually paying attention to the treatment path that you're trying to follow. There's a question here: how does venetoclax and obinutuzumab compare to acalabrutinib for CLL treatment? Is that a chicken and egg question, or?
Well, I think they're just completely different. I mean, in terms of it's philosophically, I don't mind when I have a conversation with people about what to treat. Then it's the do you want long-term treatment or do you want time-limited therapy? One of the things that surprised me is that this was on your video. One of you, I can't remember the name of the person who was speaking, but I was quite sort of surprised by what they'd been told about venetoclax being a highly intensive, horrible treatment to have. There's a lot of stuff said about venetoclax, and that it's very difficult to have and all the side effects. And actually, venetoclax is dead easy treatment to give. You follow the recipe with venetoclax and you do it, then it's a bit, the first few weeks of treatment, 5-week dose escalation, it's slightly tedious because you might end up sitting in hospital for days, and you get given a tablet told to drink and nothing happens. So it's boring, but boring good. It's boring, indicating that people aren't getting terribly unwell. I've been using venetoclax for a few years, and I cannot remember the last person who we saw significant tumor lysis where we've had to admit them. It's really, really uncommon. And the more recent iterations of the guidance for that are that you don't that sort of 5-week risk period comes back to a 3-week risk period, because actually we see that in terms of the tumor lysis, it mostly happens when you give people the first, second, or third dose. If you haven't seen it after that, very unlikely to happen. And giving obinutuzumab, yes, you are likely to react to the first dose of obinutuzumab. It's very common. You will need to have some steroids. You probably will need to spend most of the day in hospital having it, but beyond that, it's dead easy. And head-to-head, I mean, there's no head-to-head data, but anecdotally, I found that beyond the first few weeks of treatment, venetoclax, certainly compared to ibrutinib, is probably easier. That sounds like I've got a strong preference of one over the other, but it's generally a very well tolerated. It's a very well tolerated drug. Some people get neutropenia, but that can usually be managed with just intermittent doses of GCSF, and it normally goes away by the first 3 months. And at the end of it, you've got a good chance of being in remission. I think, is it better than ibrutinib? Well, ibrutinib, the tolerability of ibrutinib is questionable. I mean, the US data on ibrutinib suggested that 30 or 40% of patients ended up coming off treatment predominantly for toxicity. Acalabrutinib is certainly got less side effects, but you are committed to taking it for a longer period of time. The other thing that may be a consideration is the impact on, coming back to our friend of COVID. there was a French study that was presented at ASH, and they looked at impact of vaccination by different types of treatments. What's clear is that anti-CD20 antibodies are really bad news for vaccine response. So obinutuzumab and rituximab really reduce the vaccine efficacy, but your response does get better. So once you've been off them for probably 12 months, and you can start responding again. Venetoclax has some effect, but probably not so much. BTK inhibitors seem to have quite a big effect. So acalabrutinib, ibrutinib, if you take them long term, that's one of the things that does significantly reduce your vaccine response. And I think that's where Helen Parry's study will be helpful. So, and this is a trial that's trying to address the question of, if you pause your BTK inhibitor, so either ibrutinib or acalabrutinib for 3 weeks, does that improve your vaccine response compared to those that take it continuously? And I think that's a sort of nuanced discussion that might have to happen as we come out of COVID, in terms of thinking, if I'm going to be living with CLL, I also want to be protected from COVID, and therefore things like, am I likely to respond to vaccines? Does that help? The other thing is that it's also kind of questions about antibody responses and how do you assess whether people have responded to vaccines. It's very easy to get antibody tests now. There was a time in which getting antibody tests was actually quite difficult, and they weren't widely available, and it wasn't clear what they meant. I think that it's now very straightforward, and I would suggest that it's reasonable to ask, because I just think everybody should have an antibody test done. It doesn't guarantee that you're immune if you've got antibodies. It also doesn't guarantee that you're not immune if you haven't got antibodies, but it does help. And it's one of the things that I think you might take into the mix. Now, I'm going to, I can get shot down by virologists here for saying things that antibodies mean a thing. But, if you're making a decision, for example, coming out of shielding, for example, you've been working from home and now it's having to come back and say, I'm going to go back to work again, or I want to go on holiday, or, want to go and do something to see people. Actually, knowing your antibody level is something that could be helpful. It's not clear what antibody level is protective. And indeed, can you use antibodies as a surrogate for protection at all? But I think what is clear is you need plenty of them. And so one of the things when you get your antibody results, it's not just positive or negative. So the antibody test that we do has a sort of range that goes up to 250, and everybody's above 250, you just get a level of 250. And if you immunize somebody who's got a normal immune system, it will always be above 250. It's often in the thousands. If you immunize CLL patients, sometimes what you see is the antibody level comes back as being 12. The question is what does that mean? And I'd be hesitant there. You've got to look in sort of like, it's not just positive or negative, although anything above 0.8 is positive, 0.9 is unlikely to be protective, but I think it's helpful to get it. I also think it's helpful to do it serially as well, because as I said, vaccine response in CLL, vaccine response in general gets better with each dose of vaccine. If you're on treatment, you might stop your treatment, you might have another vaccine, and then you can have your antibody test and see. And it's something that can be helpful to actually inform that sort of risk-benefit profile. One thing that does come up though is that, what other determinants of vaccine response are there? And so can we measure T-cell responses? So for those who don't know, two types of lymphocytes, B cells and T cells. They both do different things in your immune system. CLL is derived from B cells. T cells in CLL patients don't work so effectively, but when you respond to vaccines, you have antibody responses, but you also have cellular responses, particularly T cells. And one of the things that Helen Parry's previous study has shown that you can see T-cell responses in people who haven't responded to antibodies. So the fact you haven't got any antibodies doesn't necessarily mean that you're completely non-protected. But the challenge is that measuring T-cell responses, you can do it, but it's more of a research tool rather than a routine, something you can get routinely. I'd love to be able to do it, but it's not something you get as a routine diagnostic test. But I think coming back to this in terms of how we address this, in terms of vaccines. Have your vaccines, but I would say also maybe thinking about getting tests done as well. But again, it's another thing that comes back to the sort of message here, is that you may have to stamp your feet a bit to be able to get it. Speaking to your GP, speaking to your team, saying, because there isn't really a valid reason not to do it. It's true that we might not know what the results mean. It's true that it might be negative, but I think it can give useful information. And we've got to have some means going forwards, coming back to the question of how do people with CLL live with COVID, of being able to risk stratify to determine how can you protect yourself, what information can you get, so that you can then think about how I'm going to live my life, and that's part of it.
Because there must be a group of people now who are seriously looking at how they're going to, we're all being told to go back to work.
Yeah.
And public transport's okay, etc. We'll see. But so there must be a group of people out there who are now beginning to wonder what their strategy is going to be for ensuring their safety.
Yeah, I mean, I guess the difficulty there is what you've told your employer. If you haven't told your employer, then you're on incredibly thin ice, because now announcing you've got CLL 2 years down the line, it can be very challenging. If, however, I suppose under employment law, if you've told somebody you've got CLL, then they are obliged to make reasonable adjustments to your workplace. It's a protected characteristic. So I always encourage people to be open and honest. It's very difficult in the situation. I'm not an employment lawyer. If you've just started a new job, do you really want to be telling your employer that you've also got a health condition as well? If you've been in a job for more than 2 or 3 years, when you're then protected, well, I think that the sensible thing is to declare it, because of the fact that you've got a lot of protection to be able to do that, and that's something that can then open up a helpful conversation, hopefully. And not all employers are clearly as helpful as others, just to be able to say, how can I come back and be productive and useful, but also to be protected.
But the old rules of face mask, wash your hands, distance, all these things still apply, I guess, in the end.
We'll do them anyway, but I mean, you can't necessarily persuade everyone else to do them, but I think it's something that you can take it under control, protect yourself.
Okay, any other I mean, there's still lots of COVID questions we could jump back into here.
So
questions about monoclonal vaccines. There's a question here: is acalabrutinib simply a better version of ibrutinib?
Yes, essentially, acalabrutinib is a better version of ibrutinib. So if we're looking at sort of where treatment might be going for CLL, where's it going forward? Given the choice between acalabrutinib and ibrutinib, I'd have acalabrutinib every time, because there's the randomized trial that looked at them showed that they were about the same in terms of efficacy, and this was done in the context of relapsed disease. And the side effect profile with acalabrutinib was preferable. So I think there are very few, I can't really think of any good indications where I would say I'd want to be giving somebody ibrutinib. There was a question about atrial fibrillation. It's something that side effects from BTK inhibitors, bleeding and bruising, you've heard is something that's a common side effect, and it occurs both with acalabrutinib and ibrutinib, but it's mostly minor. Atrial fibrillation is something that is a bit of a, it is an issue with treating with BTK inhibitors. It's quite common with ibrutinib, depending on which series you look at. Maybe 10 to 20% of people can get atrial fibrillation, whereas acalabrutinib, it's probably closer to 5% or so. But I think that there was a question about what to look out for. If you notice that you're getting an irregular heart rate, you're getting any kind of feelings of unexplained shortness of breath, or kind of pounding or pain in your chest, these are always things that you should get those checked out, because it is definitely it's a real side effect. It can normally be managed with medication, but most of the time you don't necessarily have to stop your treatment. But it is certainly something that I would be wanting to bring to somebody's attention if that was a problem.
We have, it's difficult to know what to advise really. We have somebody here who had a third vaccination, was quite ill afterwards for COVID, and she's worried about having a fourth. I mean, I would just say have the fourth, but you got a particular view on that?
Yeah, I agree. It's difficult to know. It depends a bit on which vaccines had. I mean, the likelihood, given that almost all of the third vaccines were mRNA vaccines, and most of those were Pfizer. There is a possibility of being able to get the Moderna vaccine if you've had a bad time with Pfizer. Equally, it's not impossible that you could go back to AstraZeneca, but that's probably less effective in that context. Again, I think it depends. It's all about risk benefit here. I might be looking and saying there's cases whereby if your antibody level was really high, then that might be something that could be added into the mix, and you could watch that. But I think that, in general, there are received wisdom is that for people who are vulnerable, then having more vaccines is better, and that vaccine response can wane with time. I think what's unknown is what's going to happen going forward, though, is that I think that what was somebody sort of pointed out, we cannot be revaccinating the whole population every 3 to 6 months forever. And there is going to need to be a view taken on this as to how frequently people are vaccinated, what's the optimal thing, and who gets them. I think that almost inevitably vulnerable individuals, including CLL patients, the recommendation is going to be for ongoing vaccination. I think it's going to be part of life like flu going forward. And the vaccines are probably going to have to be tweaked like they are with flu vaccines to see what's happening with emergent strains of COVID. I think what I've seen with COVID vaccines is that some people have a horrible reaction to one vaccine that's a bit difficult to predict. Bad with one, fine with two, okay with three, terrible with four. It can be a little unpredictable, but I think that in general, vaccinate unless you've got a really, really strong reason not to, because there is a definite benefit here.
I know that I struggled with my second vaccine, but my third, I didn't have any problems with at all. It was just
no. And I think it's, I don't know, anecdotally, it seems sort of, I have flu vaccine every year. Some years I feel fine, other years it makes me feel absolutely awful, and no particular rhyme or reason for it. So I wouldn't be put off. I think that clearly going back to earlier days when people would have the concerns about severe reactions, particularly to the AstraZeneca vaccine, the risk of thrombosis, which that's all very small print. I think under those circumstances of life-threatening reactions, then that needs to be definitely taken into account. Feeling a bit rubbish, it depends on how rubbish it is, but I still would recommend going ahead with it.
Stepping back to treatments, what's the future beyond acalabrutinib and venetoclax, do you think?
Okay, so I think that the future is likely to be combination treatment. In terms of what the combinations are, that's less clear. So there's been some data now, so 2 trials, so the Captivate trial and the GLOW trial, and then FLAIR as well, that have all looked at combinations of ibrutinib and venetoclax, including in the frontline setting. And I think that time limited MRD directed treatment is probably the way that we should be going. There's lots of reasons for that. And I think being MRD negative I think should be the goal of therapy. That's been challenged with BTK inhibitors because they don't make anybody MRD negative, but if you are, it does mean that you've got the opportunity then to stop your treatment. And I think there's huge numbers of reasons why it's a good idea being able to come off treatment. So reduction in side effects, there's a cost benefit. And thinking about COVID, there's also probably a benefit in terms of your immune function by not having treatment long term. But we need longer term data really to see what the impact of that is. And then static trial will be asking also an important question, is that we need to get away from this. I think getting away from the treatment of just saying, let's just give everybody a BTK inhibitor forever. We've seen this in CML, for example, so similar parallels to this, treating with a targeted treatment that if you respond very well to it, then you can probably stop it. So that's, I think, where we will see in terms of frontline treatment. And actually, I think many people will do very well with that. I mean, the difficulty is it's going to take years and years to unwind to actually understand that, because, you know, where we sit at the moment, whatever you have in the frontline setting, statistically, you've got a 95% chance of being in remission or better. And the average remission duration, if you have FCR, or you have ibrutinib, or you have acalabrutinib, or you have Veno, whatever you have, is probably going to be in excess of 5 to 6 years. So if you're going to compare anything, it's going to take quite a long time to see whether or not that's better. Areas that I think we will also see that are changing, though, are going to be potentially for the areas of unmet need, which are still the same as they were. When I used to give talks about unmet need, one of the things that used to be big on that was how you treat people who are frail or elderly. And that, I think, thankfully, has largely gone away. And with very few exceptions, age and performance status have stopped being major considerations in my treatment pathway, because there are very few people that you can't give acalabrutinib to, which is a great thing. And so that's, to me, has stopped being such a pressing problem it was before. When previously, when you had the choice of FCR for people who were fit, or chlorambucil or something useless for those that run fit, and that's now largely gone. P53 dysregulation is still an issue and is going to remain an issue, because none of the things that I've talked about, they're better than what they were before, but we haven't cracked that yet. And there still does need to be something, I think, that's different. It's a fundamentally different disease that needs to be treated differently, and I'm not entirely sure that we've got the solution to that at the moment. And then, of course, there's management of relapsed refractory disease. Where do we go with people? Because, you know, I look through the history of CLL sort of 2010 onwards. If you were diagnosed in the 2000s, then you might have gone through some chemo and then had some ibrutinib and then had some venetoclax, and it was all good because it came along in a timely way. And venetoclax came along just as we were seeing people starting to relapse significantly from ibrutinib. But we are now going to be coming into the next few years of what happens to people who are starting to fail previous treatment with ibrutinib and previous treatment with venetoclax. Where do we go with them? I think one of the areas that might be interesting is all about immunotherapy. So utilizing different antibody treatments. So bispecific antibodies look interesting. I think that's going to be an area that we will see more of, and that's in trials. So these are using antibodies so rituximab is an antibody that's just directed at a target on the CLL cells. A bispecific antibody is targeted both to the CLL cells, but also to immune cells, be it T cells or NK cells. So it's by them being able to bring your immune cell into proximity to the CLL cell to then destroy it. Because we know in CLL, the interaction between the CLL cells and the cells in your body that should get rid of them doesn't work. It's broken. And so that sort of restores that. And that looks very interesting. There's a few studies coming through in that, which I think we'll see more of. CAR T therapy in the relapse setting, it's something that has always looked promising, but not quite there yet. I still think that's one for trial. So CAR T treatment, it's a not dissimilar approach to using bispecific antibodies, but rather than using an antibody to bring the T cells to the CLL cells, you're changing the T cells to make them recognize the CLL cells. So you're actually reprogramming them. But the problem there is those T cells in CLL patients don't work very well. And so consequently, if you try and make the CAR T cells, they're relatively ineffective. So it works in some, but not others. And I think that where we need to understand those sorts of treatments is where they fit. And probably what we need to be doing is identifying people who are not going to do so well, either because they've got P53 deletion or because they haven't had a great response to their ibrutinib, or they haven't had an MRD negative remission to venetoclax, and saying, let's bring those in earlier rather than later, because by the time you get to failing everything, then those sorts of treatments don't work terribly effectively. And then clever treatments that might be coming through, some interesting work. So we know that for people who have ibrutinib, that the CLL cells can mutate. So the target of the ibrutinib is mutated. And so the ibrutinib no longer works anymore. So the Bruton's tyrosine kinase, which is the target from it, becomes insensitive. You can see a similar type of thing that occurs with venetoclax as well. And so there's some I think some very intriguing things coming through about called protein degraders. So they're actually, these are it's almost like an enzyme, something that will specifically work to degrade. So rather than the ibrutinib, which blocks it, binds to it and blocks it, this is something that actually tries to break it up to stop it working. And so BTK degraders, or BCL2 degraders, is the target of venetoclax. They also look, this is quite a long way into the future, I think, but this is something that's coming now into trials. And so I think that in terms of, I don't have the answer in terms of, situation. What do you do if you're sitting with your doctor and saying, well, I've had FCR, and I've had ibrutinib, and I've had venetoclax, and it's stopped working. Where do I go now? There isn't a standard treatment. I mean, this is something that I think we're going to need to be looking at trials, and always encourage people, it's speaking to people saying, what are my options? And really pushing the issue and saying, okay, if you've not got anything here for me, what about trying to find out somebody else that has? Because there are things that are coming through, but they're not going to be available in a DGH. They're not going to be available in a lot of centres. But it is something about coming back and asking those questions, just pushing it, because I don't say that we've got the solution to everything, but equally there are a number of new treatments that are coming through in trials that are showing actual realistic chances of working. It's not just saying going off to pursue therapy that's unlikely to work. I think there's quite a lot of promise from these, and that's where the future may lie.
Okay, thank you for that. We've just got a few minutes left, and then I know you have to get off and actually talk to patients face to face here, which is very disturbing. But
my day job, you mean? Yes.
Oh, that's the one. Yeah. So I don't know if there's any conclusions you want to pull in, or any particular questions here, because there's there's over 100 questions, as you can see. We haven't had a chance to answer all of them, although I think we've answered a good number in one way or another. Anything that you particularly want to add?
So no, I don't think so. I guess just to summarise about things, that I'm all for patient empowerment. I guess that's why the audience is here. People are taking an interest in their own treatment and their own care, and actually it's not all, regrettably, not everything just gets presented to patients when they need it. They might not get the best COVID treatments, they get access to things, the testing, the treatments. It's not all there everywhere. I can't change that, but I think just ask the questions. Sometimes you've got to be a bit more persistent, but you will do. I can't speak for my colleagues, but I get asked lots of questions. Some patients don't ask me anything, others will come in reams of data and stuff. But I mean, I think from my perspective, it doesn't bother me. Ask me a question, I know the answer, I'll try and do it. And I think don't be afraid to do that. COVID, you've got to push things. With the best will in the world, the rules about COVID change every single week, and it's impossible to catch up with it. And I think that can't be overly critical of the government. The government, the system's trying to do this. It is imperfect, and trying to do everything in real time is incredibly difficult. And I think there's a willingness to help people who need these need COVID treatments, but sometimes you may have to go after it yourself. And I think the other thing is, as we come through out of COVID, let's try and think of common sense. I get asked questions in clinics. Some of them are very general, which is reasonable, and some of them are very specific. Can I go on holiday tomorrow, or what about this, or what about this situation? There's a lot of room for common sense in medicine, including this. And I think that it's just thinking about it. How can we assess it? Think about what the risk is and what we can do. And I do think that I can see something coming out of this where people are going to be able to come out of shielding, to be able to live reasonable lives, to be able to protect themselves. But it is going to come down to making sensible decisions, trying to balance risks, thinking about what the opportunities are, getting an antibody test done, thinking about what you can do to protect yourself, because the world at large, unfortunately, isn't going to protect everybody. But you know, that's the challenge. I think that if you're living with immunosuppression, whether it's COVID or whether it's anything else, it's another example of what people have to live with.
Adrian, thank you very much indeed for your time today, and thank you again for stepping in at such short notice.